Welcome to the very first discussion at the Geneva Health Forum. My name is Ariane Alcorta, and I will be your moderator in this session. It goes without saying that this year's forum looks a little different. You're watching us from the comfort of your homes, and I'm the only presenter here in the studios, respecting, of course, more than a 3-meter distance from our cameramen, who are all wearing a mask. We encourage you to leave your comments and your questions in the chat box of this session, and we will address your questions at the end of this panel. 1 year ago, the World Health Organization determined that 2020 would be the year of the wife and the nurse, to recognize and advocate for their essential roles globally. If there's one thing that nobody anticipated, was how brutally the global emergency response was going to be tested this year. The COVID-19 pandemic brought many of the nursing advocacy plans to a disruptive halt. At the same time, never have the roles of the nurses gained more spotlight than in 2020. Never have nurses been more vital to combat the front line of this pandemic. Nurses and midwives are often the first and only point of care in many communities. With the preparation for a potential vaccine, the world needs them working at the full extent of their potential. According to the 2020 State of the World Nurses Report, nurses and midwives occupied the largest group in the health sector, accounting for nearly 60% of all the healthcare workforce. Nevertheless, the expansion of the nursing workforce is not equitable. It is insufficient to meet rising demand, leaving some populations behind. This is why I would like to start the discussion with Ms. Elizabeth Iro, Chief Nursing Officer of the WHO. She's also a coordinator of the State of the World report. And so, Elizabeth, good morning, and thank you for joining us today. It is a pleasure to have you. This year, we've seen how unprepared the world was for a pandemic. Nurses have experienced shortage of beds and medical supplies, including personal protective equipment. Reports have exposed their exhaustion and even fears of psychological fears while witnessing corpses of patients and even colleagues piling up in the most affected countries. How urgent, Elizabeth, do you see the advocacy for nurses worldwide? And how was the year of the nurse and the midwife designed to fight for their rights and roles?
Thank you very much, Ariane, and good morning, good evening, good afternoon to those who are listening in and to the program, and also I extend my greetings to my colleagues on the panel this morning. I think the COVID-19, if I could start there, the COVID-19 pandemic in this International Year of the Nurse and the Midwife has definitely put a dual spotlight on nurses and midwives. But I think this in itself has provided the platform for identifying opportunities and also for recognizing some of the challenges to enable us to advance the nursing and the midwifery professions. It's an excellent time, I have to say. It's a sad time that we have lost colleagues because of the COVID, and those who have actually been infected with the virus as well. But I think it's also the opportunity to raise the profile of and the status of nurses and midwives. It's a time, I think, to really leverage for that investment in the professions. For many decades, nurses and midwives have saved lives. They have worked to promote, to protect, to maintain health and well-being of populations, and response with necessary interventions in times of ill health or health crisis or emergencies, as we've seen with COVID-19. And we see them during this crisis continue to provide the essential health services, from caring for mothers and newborns, giving life-saving immunizations through care of the older people in many health settings. Where their role is well established and enabled, we know they can be effective advocates for integrated patient-centered policies and practices. In many settings, as you've highlighted, they can be the allies of local leaders and professionals in other sectors. They can encourage the intergeneration connections, communication and solidarity in their communities, which are proving so important in this COVID-19 pandemic. Of course, the nursing report has provided the data and the evidence and shown that we need to create at least 6 million new nursing jobs by 2030, and primarily in low and middle income countries, particularly those places with the lowest number of nurses per population. Without increasing the number of nurses working in these countries, the ability to adequately respond to the COVID-19 pandemic and similar crises in the future is compromised and will jeopardize our collective ability to achieve UHC and the SDG targets. Nurses and midwives play the fundamental role in service delivery, as they tend to be, as you said, the first point of contact within the health system for most people. This is the most notable in the rural and vulnerable settings. They're the first, they're the key for connecting people to appropriate timely information, to services, to referrals, to follow-up, continuity of care, linking the home with health facilities and long-term care facilities and everything in between. In this respect, we recognize that advanced practice nurses, appropriately enabled and supported, can provide highly effective preventative and primary care and treatment of NCDs, as well as other services instrumental to achieving UHC and the SDGs. This level of nurse could be leveraged to provide advanced clinical services in routine care or in emergency preparedness and response. Increasingly, the use of digital technology has provided new ways of working and connecting with each other, from more flexible ways of studying to managing patient consultations remotely and connecting with colleagues in main healthcare centers. COVID-19 has definitely forced us to look at new ways of working and how to enhance our practice to ensure healthcare services are provided to those who need it. Nurses and midwives in their current positions need to have the right competencies to address population health needs. That means adequate education preparation, as well as the ability to develop and maintain new skills once they're in the workforce. Education preparation needs to include the appropriate orientation of primary health care, health emergencies, interprofessional service delivery, and other public health priorities, taking into consideration, of course, the local context. There's also a documented gap in the capacity of education and training institutions in terms of the number and preparation of faculty, the infrastructure and technology limitations, and of course the availability of the clinical training sites. These capacity gaps compromise the quality of the education. They also limit the number of applicants that are admitted to nursing programs and ultimately the number of graduate nurses who are available to enter the workforce. COVID-19 precautions present a particular challenge to educating nurses, as most institutions are forced to rethink how they deliver course content safely and remotely. Curriculum now also need to incorporate how future health professionals utilize technology to provide telehealth and communicate through virtual as opposed to in-person means. I think just last week we saw in India, Indian midwives conducting virtual role play as part of a facilitating midwifery education program. So, this is fantastic. Countries must have nursing education that prepares graduates to join the health workforce with the required knowledge and competency. For some countries, it may require reorienting education towards primary healthcare, emergency preparedness and response, interprofessional education, and ensuring digital health literacy of their graduates. For others, the pandemic has highlighted the key roles of nurses in providing health service, and they may wish to expand that production of nurses at the advanced practice nursing level. Additionally, retention of nurses and midwives in the health system is critical, and this will require governments and employers to ensure that decent work conditions with regulations on working conditions such as social protections, working environment, minimum pay, hours of shifts, etc., are in place. In countries where the regulations on working conditions are not in place, this absence has contributed to stress, burnout, absenteeism. They can cause a substantial decrease in service delivery and compromise patient safety. What is also shown by the nursing report is that migration of nurses has impacted the distribution of nurses around the globe. This continues to increase, and there is a big disparity in the reliance on nurse migration by country income category. Countries that are heavily reliant on foreign-born or foreign-trained nurses should look to increasing their domestic supply. For countries losing nurses to migration, attention to working conditions to retain nurse may be in order. The WHO Code on Ethical Recruitment of Health Personnel provides some guidance in this area. So as we focus on health and health systems, the health and well-being of the health workforce, and especially the nurses and midwives, should be prioritized. COVID-19 has shown the critical role nurses and midwives have in our healthcare services globally, and countries must invest in their education, their leadership, and ensure they are enabled to practice safely. The safety of patients is paramount, and nurses and midwives can ensure this safety if they are also safe to practice. In respect of nursing leadership, the strengthening of it is important that the nursing perspective on healthcare matters is represented in panels that produce recommendations, clinical guidelines, national research agendas, and public health planning committees. This is crucial in situations like our pandemic response. For example, planning the immunization implementation for an eventual COVID vaccine. The data and the evidence from the nursing report is providing us with a roadmap to advance the profession. It has also revealed some shortfalls in the data. However, recognizing their centrality in multidisciplinary teams is encouraging, and we need to optimize their scope of practice in locations where there are no other health professionals present. The Midwifery Report 2021 will also provide critical data and evidence to strengthen the profession. The chronic underinvestment in nursing and midwifery education and training in some countries, and the mismatch between education and employment strategies in relation to health systems and population needs are contributing to the shortages. These are compounded by difficulties in deploying health workers to rural, remote, and underserved areas. In this, the Year of the Nurse and the Midwife, WHO has recognized the opportunity this designation provides for collaboration with key partners and positioning nursing and midwifery as the most trusted profession to drive for policy changes and call for investment in nursing and midwifery jobs, education, leadership, and quality practice in order to achieve universal health coverage and the global goals. The nursing reports have provided the data and the evidence and the roadmap to take this agenda forward through policy dialogue with countries and also through development of our next global strategic direction for strengthening nursing and midwifery. So I think, the time is now, but we have a lot of work ahead of us. Thank you.
Thank you so much, Elizabeth. Indeed, really interesting to see how the education and training is so crucial in the world today, especially for nurses and especially in the times of the pandemic that we're living. Thank you so much, Elizabeth. I would now like to invite Mr. Howard Caton to the discussion. He is the Chief Executive Officer of the International Council of Nurses. In fact, ICN is one of our special guests in this edition of the Geneva Health Forum. ICN represents more than 130 nurses organizations nationally, which encompasses the 27 million nurses worldwide. Howard, what would you say is the most important challenge that nurses are facing worldwide, and how do you see the objectives of the International Year of the Nurse and the Midwives aligning with the healthcare needs today?
Good morning, Ariane, and also good morning, Elizabeth, Susmita, and Rosvita. It's a pleasure to be with you and to welcome everybody, whatever time of day or evening it may be for you. And I'm really grateful that the Geneva Health Forum have given this opportunity to focus on nursing in midwifery. In itself, the fact that such a respected and august health forum is putting time aside to think about nursing and midwifery is an important step forward. It's clearly related to the year of the nurse and the midwife. I would like to see all other health policy summits, meetings, discussions taking this approach and putting nursing much more centre at its thinking. You said we've got 130 plus national nursing associations, and what that's enabled us to do is to follow the course of the pandemic around the world, but also to be in touch with what's happening very much at the front line. And I just want to share perhaps some harder messages about the reality of many of our nursing and midwifery colleagues over the last 9 months or so. Elizabeth rightly mentioned a number of issues, PPE. Right from the get-go, it was clear to us that nurses were saying that they didn't have sufficient supplies of PPE. In some places, they had inadequate or fake PPE. We were very concerned, obviously, as to what that meant for the impact on those nurses' health. We've been monitoring and tracking infection rates. It's very difficult because there is no standardized and systematic collection of data in relation to infections and deaths of health workers. Some countries do it, but many don't, and then it isn't aggregated and disaggregated in the way we'd like to see. We think on average, the healthcare worker infection rate is probably around the 10% mark. Just think about what a huge number that could be if there are if we now 50 million plus infections around the world, 4 or 5 million could be healthcare workers. Tragically and sadly, we now know through the monitoring we've been doing that 1,500 nurses have died as a result of contracting COVID-19, but just in 44 countries. The true number will be higher. 1,500 is the same number of nurses we lost during World War I. And then we hear the stories of what that impact that has on the nurse. You imagine going to work being concerned about your own personal safety, but how would your family and friends feel about that? Nurses whose children ask them whether they have to go to work. Nurses who've removed themselves from the family home so that they can work without risk to their family and friends. And then think about what the mental health impact on all of that is in terms of your own well-being and safety in your families, but also that we're seeing nurses stepping into the shoes of relatives even more than they normally would do, because relatives are unable to visit hospitals, to be the hand, to hold, the eye, to look in. And against this reality, this experience that nurses are going through, and this may shock you, it shocks me, the examples around the world of where nurses have been subject to abuse, discrimination, victimization. And this isn't just in places which might be far away from us here in Geneva. Just last week, reports of nurses being verbally abused in Wales, nurses who have been unable to renew their tenancies for where they live or to get childcare because of fears that some have about whether they will spread the virus or not. So, just how tough this is and the challenges that nurses and midwives are facing, cannot be underestimated or underrated. What are some of the reasons then? What are some of the reasons as to why this is the experience of nurses, indeed other healthcare workers? People say the world health systems were not prepared enough for COVID-19, and that's undoubtedly true. Those that were better prepared and had recent experience of infectious diseases appear to be coping better. But Elizabeth mentioned the state of the world's nursing. 6 million nurses short we went into this pandemic with. Think of that in terms of, out of a population of 27 million, that's 22% short. Think of it in your workplace. If you went into work and 1 in 5 of the people who should be there weren't there, what impact would that have on you? What impact would that have on the service that you delivered? Would you stay in that environment? Would you continue to work there? I think that nursing and midwifery, the shortages, the lack of investment, is emblematic of our health systems failing to be prepared. So we are really now at a juncture, at a moment, at a time where we need to see hard actions, deliverables. We need to move away from applause and clapping. Her Royal Highness Princess Muna said to the World Health Assembly just last week, applause without action is unacceptable. And I support and endorse that absolutely. But I also want to just think about some more positive messages about the potential of nursing, and Elizabeth has touched on this as well. If we think about the big health challenges our world is facing, non-communicable diseases, access to healthcare, prevention, public health, mental health, lack of investment and support for mental health, these are huge global health challenges, but they are all areas in which arguably nursing and midwifery have been the most important professions leading the delivery of services. They provide access. It's high quality. Patients like it. The outcomes are great. Elizabeth talked about the evidence, and some of that is in the State of the World's Nursing Report. It's almost like we have the solution to many of these challenges right under our noses. Nurses and midwives have been hiding in plain sight. How do we remove those cloaks of invisibility, that camouflage, and invest and bring forward and capitalize on what nurses can do? Arguably, I think that what we all wanted to achieve by having a year of the nurse and the midwife, to raise the image, to show the reality, none of us would have wished for the pandemic, but the pandemic is demonstrating that in an even more powerful way than having a year of the nurse could. But we need to see the investment, as Elizabeth said. I think there are some deep-rooted gender issues in here as well, as to why, as I said, this the solution, the investment, the lack of preparedness has been allowed to continue for as long. And there's one other thing that I just wanted to say in terms of the health challenges that we're facing. One of those changes which health systems are trying to bring about, which I think we perhaps don't talk enough about, is trying to have more people-centered, person-centered health care. What does that really mean? Well, and I might not have this absolutely correct, but I think it's a response to a medical model of healthcare where doctor knows best, patients are diagnosed, told what to do, and they take a slightly subservient role, into a different relationship where we as people receiving healthcare, our partners, have access to information, jointly decide decisions about our health and our well-being, have people who stay with us on our health journey to support us to make the decisions that we want, and take a more holistic view of our health, not just our physical but our mental health, within the context of the communities that we live in. And I absolutely support that change of direction. I think it's being driven by the way people across society think and behave, and what they want to see from their health services. And yet again, it is nurses who I see who are ideally positioned to support that change in relationship with our own healthcare and with our own with our own health services. So there is something perhaps even more meaningful than the money, if there ever can be, in the investment, but about a mindset and a philosophy of care, how we want to live, how we want to, and what we want our relationships with our health professionals to be like. Final point from me is that I absolutely want to endorse what Elizabeth said about leadership. I think to get this done, it needs, of course, it needs the effort from the front line. But I think that we need to hear and see and be advised by these nursing leadership voices at all levels through our health systems. It would be very easy, would it not, for all countries to commit to having a chief nursing and midwifery officer right here, right now, this year. At least 30% don't currently. I think the true figure could be even higher, because if you say that I don't just want somebody in a title, but I want them to have the staff to really be a leader and to have a budget as well, I think the figure is much higher. And I think health systems, the providers of healthcare within our countries as well, do they have a senior nurse leader at an executive level providing this advice and this input? And if they did, I think that would help for everybody to get the power and the potential of nursing. It would bring this nursing perspective into the heart of decision making about how services are delivered, and also into political decision making as well. So that's something that we could get done just this year. Ariana, I'll leave it at that. Thank you.
Department, the need to educate, to train the nursing workforce, so that we can be better prepared to combat this pandemic. Thank you so much. I would now like to invite your colleague, actually, Ms. Roswitha Koch, also a board member of the International Council of Nurses and a senior member of the Swiss Nurses Association. Roswitha, I would like to talk about a bit of a leadership, sort of what Ms. Elizabeth and Mr. Howard were just saying before, the importance of having a voice. And you are really very involved in this kind of sector, in Switzerland in particular. So can we elaborate a little bit more about the need of these voices?
Thank you, Ariana, and hello to everybody. For the Swiss NNA, the major goals of the Year of the Nurse was to have nursing care in the Swiss constitution, to be seen and to be better recognized as being part of the constitution. And we also wanted to celebrate our important year, the Year of the Nurse and the Midwives. We wanted to celebrate partly together with the midwives and with the public. Getting back to our main objective, having nursing in the constitution, for the Swiss nurses, having more autonomy has been a paramount goal for many years. We failed twice in a parliamentary process to have this autonomy in the laws. So the Swiss Nurses Association, together with partners, started an initiative. This means we had to collect 120,000 signatures among Swiss citizens and handed over the signatures to the government. In our law, we have the possibility to have a referendum of the Swiss population on our initiative. Between the referendum and the handing in of the 120 signatures, there is an intensive political process. So the government and the parliament can say whether they support, reject the initiative, or whether they propose an alternative. We are still in the middle of this process, and the first wave of COVID-19 hit us in March, April. Switzerland has been very touched, and we had issues like most other countries, that there was not enough protective equipment, especially protective masks. We also had problems concerning the labor law, which was suspended for some time. And when COVID numbers went down and the number of hospitalizations went down, nurses were really tired. As during the first wave, the public had given a lot of applause, and there has been a lot of appreciation for nurses all around the country. The nurses were expecting, or we were expecting, that our initiative would now get a lot of support by the parliament. In June, the parliament discussed our suggestions and did not increase or improve their position. They just kind of behaved as if there had been no COVID pandemic, and as if there had not been nursing being recognized as one of the very essential professions in controlling the pandemic. You've heard a lot of this from Howard and Elizabeth. I just can support this and confirm that we had a very similar situation in these countries as we had in many others. To get to the nursing initiative, many of its objectives are very close to what we have already heard from ICN and WHO. So we want to have more nurses being educated, as currently Switzerland only produces 43% of the nurses needed per year. We want to have needs-based nurse staffing because there are not enough nurses in the services, and many nurses leave the profession very early. Then we still want to have nursing autonomy, to have pure nursing care carried out without having the need of a physician's prescription. And we definitely want to have better nurse retention. So when this, after the first wave of COVID, all these demands were not more supported than they had been before, the nurses really became unhappy, unpleasant. They felt instrumentalized. Also, when they saw that the preparations for a possible second wave did not really deliver as we had expected, like the contact tracing didn't work out well enough. So the nurses really became unhappy, and we heard from many members that they were going to leave the profession sooner or later. So all these led to, in the end of October, to different activities in the different regions of the country. And
something that you're working right now to correct all of this? We were speaking about all the challenges that nurses are experiencing in Switzerland. Are there any particular steps that you're planning to take in the rest of the year or in 2021?
Well, there is one major step. We also got out of the years of the world status of the world's nursing report from WHO and ICN. We really see that it is absolutely necessary to have nurses in all the decision-taking bodies, to have nurses in the Corona Management Task Force, to have a government chief nurse, to have the voice and the views of the nurses everywhere, and to have influence, to be really part of the decision-taking team and not just used for managing crises and other situations.
Perfect. Thank you so much. I'm going to continue now with Ms. Susmita Sinha to kind of follow up a little bit about in this subject. She's the founder and president of the Health Law Institute, which is in charge of improving health workers' legal awareness and literacy to enable them to better address regulatory and human rights challenges in their day-to-day work. So we were talking a bit about what the challenges happening in Switzerland. Can you talk to me now about the challenges worldwide that nurses may be experiencing regarding their human rights challenges in their daily work and some of the actions really that we should be taking right now to correct this?
Hello to Elizabeth, Howard, and Roswitha. It's lovely to be here. And this is such an important topic, so I'm very happy to be able to contribute to this. I think just, generally, I think life keeps us teaching a lesson unless we're ready to learn it. And somehow I would say COVID-19 has been that. This is not the first pandemic, and this is not going to be the last. And we just need to know some of the things, and it seems to be happening. My experiences was, the first one was with the global epidemic of HIV/AIDS. We have seen Ebola, we have seen SARS. COVID is certainly on a larger scale than that, but it has some of the similar lessons that we can see, kind of a common denominator in many of these things. And that's why the first ever report of the state of nursing was a very important one. It highlighted many of these issues. It gave us, the positive things that have happened, but also the things that need to happen in all the sectors, whether it's jobs, leadership, and, education itself. I think Roswitha highlighted many of the issues that we have seen. To just kind of cap it over, during COVID, some of the main things that stuck out was, as Howard mentioned, PPE was one of the first things. Like we didn't have enough PPE, or there was fake PPE, or there was just guidelines around it. I think of concern was even initially when it started, where nurses were not even allowed to use their own PPE if the hospital didn't provide it. And I think it's this operating below standard of care, first of all, because of the system being overwhelmed and, having to ration ventilators, having to make, decisions, or, dealing with do not resuscitate conditions itself. The PP on that, I think, brings up other questions. It's not only to protect themselves, but it also to protect the future patients. And I think one of the discussions that's very much is not only the duty that nurses owe to the patients they're serving currently, but to their future patients, and to protect themselves. I think is one I think we've highlighted before. We actually started talking about this last year, and the pandemic has made that clear, like, where is it? So with the American Nursing Association, they did in 2015, they added interpretive statements. And two of those provisions, one is, of course, the duty to the patient, but it's also duty to self. And I think even in the International Councils of Nursing, it clearly states that the nurse should maintain a standard of personal health such that the ability to provide care is not compromised. I know it's currently going review, but that clearly states that it should allow the nurse to protect himself, not only to protect himself and his family members, but also the patients that they're going to take care of. I think this was definitely one of the things. The other thing is forced labor. I would call it forced labor, but like Rosita said, some of the labor laws were kind of suspended during this period. But we have heard reports. We've heard reports of nurses having to work long hours, not being able to take vacations, actually working when they're sick. Recently, we have been hearing, almost a state-sanctioned one in North Dakota, where COVID-positive nurses will continue to work if they're asymptomatic. I think Belgium has a similar case. And, this is not only the effect it has on themselves, like we're asking the general population to quarantine, which we're not seeing. But on top of that is that how is it compromising patient safety? If nurses are not safe, can patients really be safe in that environment? Aren't we actually making them vectors of these, of COVID to pass on to the next person? So I think these are the main things. And out of all these came whistleblower protections become very important. There were cases globally and especially in the US that we followed where, nurses could not talk to the social media. Nurses could not talk to the government organizations. There was repercussions from employers. Some of the positive things we see, some states did enact laws where they expanded protection to bringing in your own PPE if you were able to get it and the hospital could not provide it. This was, I believe, in Colorado in the US. In Virginia, they actually expanded whistleblower protections to not only being able to report it to your employer, but also to other social media as well, and to other organizations, which I think was very important. And I think in all of this, what comes out, and I think all other speakers have touched on, is leadership. Being able to influence these policies is very important. I think in some of her discussions, even with Elizabeth, what we talked about was like, it is very common in hospitals to have a physician as the person that oversees and plans for many of these policies. But I think each health worker group, and especially nurses, because as you mentioned, they're 59% of the health workforce, they provide 90% of the care of primary health care interventions. It is very important that they have a voice because they're the ones that understand the reality on the ground. And this also, brings us to de jure and de facto laws. I think the State of Nursing report did show that in most cases there were actually regulations about working conditions. I think it was stated that 94% of countries had regulations on working hours conditions, 92 on social protection, 89 on minimum wage. But, are they really there in reality? Can people access it? What's the enforcement? What's the accountability? Is there transparency? Is there engagement? And without engagement, this cannot happen. And the only way we can have engagement is when we have nurses in leadership positions. One of the things that was very clear from the report, and I think still remains a problem, is the tax on health workers. It's not only a tax and conflict situation, but like Howard mentioned, this is something we face day to day. It is very common. It is not reported as much, many times because there might not be ways of reporting, many a times because health workers and nurses in particular are very busy to report it. And sometimes they don't see anything, or there are actual repercussions when they report it. We have been seeing a rise of discrimination against health workers, abuse, those cases I think some people were throwing Lysol at nurses at gas stations because they thought they were infected. People were scared about it. And I've heard comments or suggestions that health workers and nurses should just remove their scrubs when they leave. And I understand this is a good practice from not from the point of not spreading infection, but I think almost blaming the victim of the assault for something they should have done is very similar to other things we hear about harassment. And I think this has a huge role to play with the gender component of nursing. And I think those all come in. So there are really a lot of intertwined issues. And I think the way forward we have to look at is how can we do it? International cooperation is certainly to look at, because we know there are countries that need it. I think with technology, this becomes even easier because you can have knowledge sharing and good practices. What we have seen is that knowledge sharing is not only maybe from the global north to the global south. We have been seeing countries that are able to manage it effectively, and it should be both ways. I understand that nursing is a very hands-on profession, and that's why there are many skills that cannot be transferred through technology, and being mindful of that is very important on what we can expand or not, and that's why the need for the input. What we have also seen, I think nurses deal with, is a rise and uptick of domestic violence and child abuse, and I think training nurses to spot that would be part of going forward. And certainly migrant health workers is a huge issue. And Elizabeth touched on, the code of recruitment is very important. We also saw incidences where, migrant health workers, when they work in another country, sometimes you're still not a citizen. In these cases, I know many nurses who had to start writing their wills. They had to start thinking of what would happen to their family if they lost their job. So in the US, I think after your H-1B status, you can only stay in the country for 10 days. So if you died on the job, what happens to your family? And that's something a migrant health worker faces, not only, like Howard mentioned, isolating from your family and the mental health impacts of it, but what happens to your family after that? You have to plan for that while you go in for your work and take care of other people and fill in for relatives of other people. And the need for data. The need for data is what will drive what we can do after the pandemic. So I'll leave it as that so that we can all, but I think that is one of the things, and I know Howard has been a huge proponent of this, calling out the lack of data on the deaths, calling out the lack of data on the risk of infection. I think from WHO statistics, we have that 14% of health workers, the cases are health workers, when we know health workers only form 3% of most countries and 2% in low and middle income countries. So that just shows you the difference in infection rates that health workers are facing, and of course then translate that to the percentage of nurses, and we know what's going on. So I'll leave it at that, but those were some of the points.
Thank you so much, Susmita. You really did shed a light to all of the struggles that nurses are facing worldwide, that the coming population often overlooks. So I really do thank you for that. Now, with the next question, a potential vaccine for COVID-19 may be available sooner than expected. This will be the largest vaccination movement in the century, the medical equivalent of landing in the moon. So the big question is, are we ready? Is the nursing workforce ready? Howard, I'll leave that question to you.
Thanks, Ariane. We put a statement out about this last week, and one of the reasons we put a statement out is that I was listening to the exciting news coming through. I'm sure all of you were as well, and I was seeing the scientists who've been at the forefront of developing the vaccine speaking about this. And I was hearing political reaction to it as well. And I was hearing some voices from our medical colleagues talking about how they would ensure that everybody got everybody got vaccinated. And I wasn't hearing any nursing voices. Ariana, we've said, it's a public health equivalent of landing on the moon. But the people who will get this done includes hugely nurses. Nurses are at the forefront of administering all vaccines right the way around the world. Increasingly, they are prescribing as well. I think pharmacists have a big role to play. The army are going to be really important. The refrigerated truck drivers who have to get the vaccine in cold storage around are going to be really. These are the people who we should be talking about in terms of whether and how we make the vaccination of everybody on the planet a success. But the other point is that people just seem to think that it's a jab in the arm, and it's so much more than a jab in the arm. You have got to prioritize and find the most vulnerable people. Some of them will be in hard to reach groups. We will have to deal with resistance and hesitancy from people who'll be skeptical about having a vaccine. And I bet your bottom dollar that we'll also find an awful lot of people who come forward from a vaccine who haven't accessed healthcare over the last few months, but have other health needs and issues that need support. And the people who will be doing this work will be nurses. So for me, this goes again to where is the nursing voice in terms of the big policy decisions? Where is the nursing voice in terms of managing the mass vaccination response as well? Where is the recognition that, yes, this is a logistical exercise, but it's also much more than just a jab in the arm as well? And that's why I do believe that we can get this done. But I think a start point needs to be a recognition of some of these other groups, including nurses, who are absolutely going to be critical and key to it.
Thank you so much, Howard. I would like now to start with a Q&A from our audience. And this question actually goes for Elizabeth. Do we have a chance to have a nurse as a WHO director one day?
I think the possibilities are definitely there. This is about having the capability, having the right qualifications, having that forward-thinking approach to global health. So I wouldn't rule it out. We've seen nurses in this year actually do some really fantastic stuff. We've got a nurse now who's taking a vice chancellor position in a university, and it's the first woman. So we've seen some, great shifts in terms of where nurses are landing, in terms of some really key organizations. So I think, this is, again, about opportunities and having the right, like I said, the right qualifications and competencies to do the job.
Thank you. And following with you as well, if you can name one challenge, the biggest challenge internationally that nurses faced during the treatment of patients of COVID-19, what would it be?
I think the biggest challenge is there's not enough of us. I mean, we weren't enough to start off with. And the fact that you're turning up and you're being the word that's been used during this panel discussions about abuse and about use. I think that goes to further reduce the interest in the profession. So I think, that for me would be one big challenge. And I think one big outstanding challenge has been for many years. And the nursing report has highlighted that 6 million new jobs for nurses are needed.
Thank you so much, Elizabeth. This question goes for Roswitha. What are the challenges, or how does challenges with doctors and nurses differentiate? Is there a difference between the challenges that doctors and nurses face?
I see that there are many common challenges, like in the around the problematic concerning PPE during the first wave. The Swiss Medical Society has made a survey among its members, and it showed that also the physicians had problems getting enough PPE. There are some differences because physicians, they have access to the decision makers or are part of the teams who make decisions. So the challenge to get a voice in the system is much bigger for the nurses than for the doctors.
Perfect. Thank you so much. Another question that we have in here, since strengthening the nurses and midwives, or the roles of the nurses and midwives, are paramount, what are the incentives that need to be included? What are the main actions to strengthen the roles? Or Elizabeth mentioned the funds. That's one of the biggest challenges that we're facing right now, getting those funds. What is the main action then that we need to implement to get those funds to advocate for the roles of the nurses worldwide? Can we start by, well, I don't know who to ask now. Can we go with Susmita? Although you can all pitch in, feel free.
I think generally the main thing is working conditions. It's improving working conditions. There's definitely a shortage, and I think we already went into the pandemic with a shortage, as Elizabeth mentioned, and we need to also increase that. But retention is a huge amount. And I think allocating, the funding could be from different international organizations. It could be international cooperation, which, under the right to health with General Comment 14, and, it always is open for international cooperation. And I think improving working conditions, because as Howard mentioned, of course, the vaccine is in the pipeline, it's coming up. And we have had huge investments, even from the private sector, so the public-private partnership on last mile delivery. And I think what people forget, to me, the most important component of the last mile delivery is the last minute delivery. And that is between the nurse and the patient. And I think that doesn't get enough support as the whole logistics. The logistics certainly are important. But if you don't have a nurse in place, or a pharmacist, I'll say, because of my background too, to give that vaccination, it doesn't matter how much of the vaccination we have, or have we got it to the point of interest. And I think there are different avenues to tap into that funding. But I think the funding that's gotten in last mile delivery certainly needs to strengthen the nursing capacity that's there, that has to be ready to give that vaccine when it comes about.
Ariana, can I jump in on this one as well? Because I think it's a hugely important question. One of the things that worries me is that whilst we're all making the case for investment in health services now, we're seeing the impact that COVID is having on our economies, and seeing the delivery of those funds over the next few years. If we're seeing economies dip, global recession could feel like a really, really big ask. And I think that we need to get on the front foot about this. And that's firstly about saying that this is a political choice. This is a political choice. Governments have managed to find, rightly so, huge amounts of money in terms of keeping economies going through the through the pandemic. It's a choice as to whether they want to find funds for health services once we're the other side of this pandemic. Again, let's have the data on this. Shine the light of sunshine on how many, not just how many nurses are being educated and employed, but how much funding, what share of GDP is being spent. At WHO have talked about increasing, to get universal health coverage done, access done. I think it's about another 1% of GDP. But let's have the data and let's shine that. And the other dynamic we talked a bit about during this conversation that I'd like to see brought much more to the fore is people who use health services being consumers. People might not like to use the word customers, but they are users of health service, and whether it is safe or not. If we know that what we're spending on health services isn't, that we're not putting enough nurses in, we know that, as Sumita has said, that the safety of staff and the safety of patients are two sides of the same coin. We can't keep patients safe if we don't keep our health workers safe. So if we're not keeping people safe, should we be providing some of those health services? I'm not making a call on that now, but let's put that debate out there as part of the political choice about how much we spend. It's not nurses for nurses' sake. It's nurses to have safe, effective, and quality health services for all.
Thank you so much. I really do want to thank you for your invigorating participation in this panel that without a doubt will start further conversations on how to improve the environment where nurses and midwives operate. Up next, before our next discussion, you will be able to clear your mind with a short yoga session courtesy of the Government of India. At 12:30, we will have our next discussion on how can the world advance towards artificial intelligence, maturity, and health.
Dear friends, on behalf of Ministry of Ayush, Government of India, I welcome you to this short yoga session. We will do 3 yoga exercises which you can easily practice sitting in front of computer screen. Let us start the session. Spinal twist. Precautions. Recent lumbar, abdominal, shoulder and hand surgeries should avoid practicing. Practicing method. Sit straight, keep your neck and back erect. Slowly place your left leg over the right leg. Deeply breathe in. Twist your chest towards right. Place the left hand over the left leg and hold the chair's backrest with right hand. Maintain the posture for few breaths. Then slowly come to the normal. Repeat this from left side. Practice this for 2 to 3 times. Benefits. Strengthens the abdominal, lumbar, thigh muscle, relieves from constipation, improves digestion and metabolism, reduces abdominal fat. Now we will practice pranayama, deep breathing exercise. Chandra Anuloma Viloma. Precaution. Person suffering from hypotension, hypothyroidism, depression, productive cough, running nose should not practice this pranayama. Practicing method. Sit straight, keep your back, neck erect, relax your shoulder, adopt Nasika Mudra from right hand, close the right nostril from the right thumb. Slowly and deeply breathe in, breathe out from left nostril. Try to feel the cold air entering and warm air coming out of nose. Repeat this for 5 to 7 times. Benefits. Relieves from hypergastritis, hypertension, hyperthyroidism, anger and anxiety. Chandra Bedana Pranayama. Left to right nostril breathing. Precaution. Person suffering from hypotension, hypothyroidism, depression, productive cough and cold, running nose should not practice this pranayama. Practicing method. Sit straight, keep your back, neck erect, relax your shoulder, adopt Nasika Mudra from right hand, close the right nostril from the right thumb. Slowly and deeply breathe in from left nostril and breathe out from right nostril by releasing the thumb over the right nostril. Repeat the practice of breathing in from left and breathe out from right. Try to feel the cold air entering and warm air coming out of the nose. Repeat this for 5 to 7 times. Benefits: relieves from hypergastritis, hypertension, hyperthyroidism, anger and anxiety. Thank you for practicing. Enjoy the GHF session today. For any queries, please reach out to Embassy of India,